Hello, everyone. Thank you for joining us today for our webinar entitled Botulinum Toxin in Movement Disorders. My name is Dee Tran. I'm Communications Editor for the International Association for Parkinsonism and Related Disorders, and I will be moderating today's on behalf of IAPRD. First, I'd like to thank our sponsors, Ipsen and Merck, for their generous support in making this webinar series possible. Today is the last in the series of botulinum toxin lectures. Today's session consists of a 20-minute presentation to be followed by 10 minutes of questions and answers. Please type in your questions in the chat box at any time, and you can help us serve you better in the future by filling out a brief evaluation form after the webinar. As with previous webinars, today's presentation will be recorded and available on demand for 1 year at our website, www.iaprd.org. And now I would like to introduce to you Dr. Sun-Ju Chung. Dr. Chung is a professor of the Department of Neurology at the Asan Medical Center in Seoul, Korea. He has more than 20 years of experience with botulinum toxin therapy and has conducted many global clinical trials of botulinum toxins. So with that, I would like to welcome Dr. Chung. Dr. Chung?
Okay. Good evening, colleagues in USA and Europe, and good morning, my colleagues in Asia. I'm Sun-Ju Chung. My presentation today topic is long-term outcomes of botulinum toxins for dystonia. Okay. This is my disclosures. I'm a current PI of a double-blind randomized parallel clinical trial sponsored by Hugel, and I have no other things to declare. This is my presentation outlines. I'd like to first mention about the long-term outcomes of dystonia, and then the concerns related to long-term use of botulinum toxin. And then I will focus on the cervical dystonia and blepharospasm because it's the most common focal dystonia, about the long-term effect and safety, and then I summarize my presentation. To understand the long-term therapeutic effect of botulinum toxin, we need to first know about the long-term prognosis of dystonic disorders. In general, the prognosis of dystonia is dependent on dystonia types. For example, cervical dystonia usually tend to worsen for the first 5 years and then stabilize. CD may spread from the neck to contiguous body areas in some patients. And spontaneous remission of CD can occur in up to 20%, typically within 1 to 3 years of symptom onset. And the remission may last up to 20 years, but almost all patients relapse. I'd like to mention about this specific issue in more detail later. Long-term complications of CD include cervical spine degeneration, spondylosis, disc herniation, and etc. CD is not life-threatening, but it can be disabling. One of the major concerns related to long-term use of botulinum toxin is the antigenicity, because botulinum toxin drugs mainly consist of proteins, and there is a chance of antibody-induced therapy failure. Depending on the botulinum toxin type, botulinum neurotoxin and complexing proteins from different protein aggregates, composition of complexing proteins varies among different toxin types. Neutralizing botulinum toxin antibody directing against the therapeutically relevant toxin epitopes reduce the botulinum toxin effect. This figure shows the development of antibody-induced therapy failure, and 100% reflect the untreated condition, and 0% reflect the lack of any complaint. injection series 1 and 2 produce the adequate therapeutic effect, but injection 10 series does not produce any therapeutic effect, maybe related to this type of failure. So antibody-induced therapy failure usually develop 2 to 3 years after initiation of botulinum toxin therapy. After 4 years of toxin therapy, occurrence of therapy failure seems to be rare. The frequency of therapy failure is 1 to 5% in focal dystonia, and there is no antigenicity difference between on-botulinum toxin A and abobotulinum toxin A. And there's a report about the higher frequency in botulinum toxin B. Risk factors include high toxin dose given at each injection series, short latency between subsequent injection series, booster injections with inter-injection intervals of less than 2 weeks, age and sex are not included as risk factors. Then what are strategies to prevent this failure? The toxin should be dosed as low as possible, and toxin should be applied with the longest possible inter-injection intervals. Booster injection should be avoided. Then I'm going to focus on subtypes of dystonia. As we know, the cervical dystonia is largely classified into 4 types: toricolis, retrocolis, anticolis, and retrocolis. And these patients show the typical type of cervical dystonia. But most previous studies reported a similar effect or side effect of botulinum toxin regardless of these types of cervical dystonia. Up to 50% of the patients with dystonia have dystonic tremor, most frequently in the head or upper limbs. This young lady shows the severe dystonic head tremor combined with left toricolis. Dystonic head tremor is often a major problem of a patient with cervical dystonia, but there has been no well-conducted study that specifically investigates the long-term therapeutic effect or side effect of botulinum treatment for dystonic head tremor. Only a few studies evaluate the tremor component using the Dewey score. In many patients with generalized dystonia, cervical dystonia is the most disabling symptom. The left 29-year-old male has generalized dystonia caused by DYTO mutation. He initially manifested with a severe cervical dystonia. That was the major symptom. On the right side, 54-year-old male has idiopathic generalized dystonia and also has cervical dystonia as the most disabling symptom. For these 2 patients, deep brain stimulation surgery may be effective treatment in terms of long-term management, but some patients do not want to receive DBS surgery for several reasons. In this situation, botulinum toxin therapy will be effective for cervical dystonia management, but there is no previous study that investigated long-term outcomes of botulinum toxin therapy, specifically for the cervical dystonia in a patient with generalized dystonia. On the left, 68-year-old woman developed the retrocolis and toricolis at year 2009, and she received the botulinum toxin treatment for 11 years. On the right panel, 78-year-old woman developed toricolis at year 2009, and she also received the toxin therapy for 11 years. These 2 patients showed good therapeutic effect of botulinum toxin therapy, more than 10 years. So let's go through in detail about the long-term outcome of botulinum toxin therapy for cervical dystonia. This table summarizes the previous study results. In the second study, authors investigated 207 patients with cervical dystonia. Follow-up period was 7 years. Abobotulinum toxin for abobotulinum toxin type toxin A, and 12 years for on-botulinum toxin A. Mean duration of treatment effect was 11 weeks for abo and 10 weeks for ONA. Side effects were neck muscle weakness 5 to 7% and dysphagia in 8%. And this study used the CGI rather than SUI or TWSTRS and showed the satisfying long-term therapeutic effect with low to average mean dose of botulinum toxin. Sorry. Okay. In another study listed in the second, they analyzed 104 patients with dystonia, and they used the botulinum toxin type A and B. Mean follow-up period was longer time period of 19 years. 70% had global rating more than 3, and mean duration of maximum response was 15 weeks. In the analysis, botulinum toxin provide a persistent improvement in dystonia severity and function for a long time, and its therapeutic effect maintained over time with minimal side effect. This another study, CD-POP, was a prospective observational multi-center real-world registry study that investigated the long-term effectiveness and safety of ONA botulinum toxin A for 1,046 patients with cervical dystonia. Mean age was 58 years. Mean dose of mean dose was 189 unit. And there was a significant improvement of patients' CGI of change, as you can see the right figure. And there was significant reduction in CD impact profile 58 scores. And 26.2% reported side effects, neck weakness, dysphagia, but those side effects were transient and recovered in all patients. This recent study, which respectively analyzed 9,252 treatment cycles for ONA botulinum toxin A, the sample size was 138 with long treatment duration of 17 years. And for ABO botulinum toxin A, the sample size was 209 with long treatment duration of 27 years. And in figure A, there was a moderate increase of dose in the first few years, which was succeeded by a stable mean dose. And in figure 2, you can see the injection interval was stable from the beginning. In figure 3, you can see the side effect. Dysphagia was 2 to 6%, and muscle weakness 2 to 6%. And in figure 5, you can see the patient reported a satisfactory effect after 86% of all treatment sessions for both products equally. This is another study to investigate the long-term efficacy and safety of ABO botulinum toxin A in 39 patients with primary cervical dystonia. Mean dose was 701, and duration of clinical improvement 93 days, and mean VAS before and 4 weeks after injection was 4.4 and 1.8. Mean SUI score before and 4 weeks after treatment was 5.7 and 3.5. And you can see in the figure in the left side, the repeated treatment led to a gradual reduction, both SUI scores assessed before and after injections. In the right figure, you can see the repeated treatment led to a gradual reduction, both VAS scores for pain assessed before and after injection. And on the left figure, you can see the repeated treatment led to a progressive increase in botulinum toxin dose. The right figure, you can see repeated treatment led to a progressive increase in duration of maximum benefit. Okay, so the ABO botulinum toxin A had good safety profiles and good therapeutic profiles. As I mentioned earlier, one interesting thing that we need to understand the natural cause of the spontaneous remission of cervical dystonia. In the paper by David Marsden group published back in 1990, 20% had a spontaneous remission that sustained for a median period of 3 years, and 87% had occurred during the first 5 years, and 9 cases sustained with sustained remission. The remission had mostly occurred after 2 years of illness, compared with 6 who had relapsed earlier age at onset compared with those with no remission. On the right panel, there was another recent study by Bhatia group in the same institution showed that complete remission was observed in 11.8%. The remission rate was higher than in blepharospasm, and remission occurred on average 4 to 4.5 years after the onset of dystonia. But majority of patients relapsed, and patients with remission was significantly younger age at onset. So both studies suggest the early age is the critical clinical feature for the spontaneous remission. Many audiences already know about the musician's dystonia very well. And this is the pianist and guitarist. And most audience in this session are familiar with the typical musician's dystonia related to Western instrument, but today I would like to share this patient with musician's dystonia related to the Korean traditional musical instrument, the gwangari. He shows severe dystonic posturing of his right hand when he beats Korean instrument, gwangari. Long-term therapeutic outcome of botulinum toxin treatment is very important for all patients with these musicians' dystonia, because it is critical to maintain their professional careers. But there are a few well-conducted studies that investigate long-term outcomes of botulinum toxin treatment for musicians' dystonia. Okay, I'll skip this slide because of time limitation. So regarding long-term efficacy and safety of botulinum toxin in focal hand dystonia, Dr. Hallett and colleagues investigated 20 patients with focal hand dystonia who had been followed more than 10 years. And in their study, musicians were more likely to wait longer between injections and had less complex dystonia. There was a trend for large benefited women, and those increased over time. And dystonia characteristics did not predict response or side effect. And there was no serious side effect or antibody-mediated resistance. So let's move on to blepharospasm for another 5 minutes. There were a few studies that investigated long-term efficacy of botulinum toxin for blepharospasm. The first study investigated 128 patients with blepharospasm with mean follow-up period of 15 years, and those of both botulinum toxins were significantly increased over time. No correlation was found between dose and occurrence of side effects, and treatment failure occurred 7% for onabotulinum toxin A and 3% for abobotulinum toxin A. This table summarized the other recent studies for blepharospasm. The first study investigated 130 patients and showed that 87% of clinicians experienced satisfactory results, and 55% of patients reported clear improvement without side effect. And other two studies listed in the second and third showed a similar long-term therapeutic effect and the side effect profiles. This is the most recently published study for dystonic hand tremor, and this study is a placebo-controlled parallel group randomized clinical trial provide level evidence to support the use of botulinum toxin injections for reducing tremor severity in patients with upper extremity dystonic tremor. Of 30 patients, 15 randomized to receive botulinum toxin and 15 to receive placebo. As you can see in the figure on the right side, primary outcome measures Van Tolosa Moraine Tremor Rating Scale total score was significantly lower in botulinum toxin group at 6 weeks and 12 weeks. But future studies are needed to assess the long-term stability of effect and side effect botulinum toxin treatment for this specific type of dystonia. So I'd like to conclude my presentation with this message. Botulinum toxin treatment provides long-lasting effectiveness and safety profiles in all types of dystonia. long-term use of botulinum toxin should be considered based on the long-term prognostics of each dystonic disorder and other treatments such as stereotactic surgery. We need to balance the advantages and disadvantages among several treatment modalities. And strategies to prevent antibody-induced therapy failures are very important. And best treatment for dystonia may be obtained when botulinum toxin treatment is used with the long-term dynamic adjustment of botulinum toxin according to dystonia evolution and integrated into multimodal treatment. So as I mentioned in cervical dystonia in general, dystonia patients. So I'd like to acknowledge my colleagues in Asan Medical Center, Seoul, especially for Seung-Yeon Lee, who made videos for this presentation. And thank you for all for listening my presentation. Thank you.
Well, thank you so much, Dr. Chen, for the wonderful presentation. And now I'd like to see if there are any questions that there's one question, and that is, are there any other predictive factors than younger age for spontaneous remission of dystonia?
Yeah, it's a very interesting feature because some patient shows a complete remission. And as I mentioned in the previous slide, the earlier age is the most clinical feature. And I think somebody said that, and according to my experience, young age patient with early treatment with botulinum toxin shows more likely to show the complete remission compared with those patients who treated later after the onset of dystonia. And other features should be studied with the well structured study design.
Okay. And here's another question, Dr. Chung, and that is, do you see antibody formation more often in patients with cervical dystonia, blepharospasm, or focal hand dystonias, or is the frequency similar?
Yeah, it's a good question because when you consider the antibody-induced therapy failure, the risk factor is the dose of the botulinum toxin. We used a much higher dose of botulinum toxin for cervical dystonia than the cranial dystonia, such as blepharospasm or oromandibular dystonia. But in my experience, the dose is important, but one of the factors is the patient component, patient factors. There are some genetic factors or pharmacogenomic factors, some patient characteristics related to the antibody formation or some other physiologic factors. So I don't know exactly about the difference of development of antibody-induced therapy failure among patients with cervical dystonia and blepharospasm or other dystonia, but the occurrence of such therapy failure may be similar among dystonia types. You know, the cervical dystonia is the most frequent, the prevalent focal dystonia. So we use the dystonia most often for cervical dystonia. So we experience the therapy failure most often in patients with cervical dystonia. But I think there is a chance to develop therapy failure in other type of dystonia, blepharospasm and other oromandibular dystonia. So we need to study those interesting, the important issue using the future study design.
Okay, and you have another question, and that is, what dose is indicated for torticollis?
You mean the dose of botulinum toxin?
I'm not sure that's the question. So yeah.
Yeah, it depends on the patient condition or complexity, because some patient is the body weight is high, or some older woman is the body weight is low. So we adjust the dose of botulinum toxin according to the patient condition. If the patient has a big young man, we need some more dose of botulinum toxin. And if we treat older woman with some muscle atrophy or some general conditions weak, we need to use the low dose of botulinum toxin. And another important factor is the severity of cervical dystonia. When we examine the patient, there's a big contracting muscle, we can use the higher dose of botulinum toxin. And if we see mild symptoms of dystonic muscle contraction, we can use the small dose of botulinum toxin. It depends on the patient condition, I think.
Okay. And Dr. Fujioka has another question for you, Dr. Chung. And that is, how do you identify responsible muscles of dystonic tremor in a clinical setting?
Yeah, Fujioka asked me a very practical question. I just usually clinical examination. Before applying botulinum toxin, examine the severity and direction of the cervical dystonia. I palpate the muscle that show the dystonic contraction, and sometimes you can easily see the dystonic muscles with naked eyes. And then I usually always use EMG needle to inject botulinum toxin, and the portable EMG give us a very useful information for the activating muscles. And then I usually follow the patient 4 weeks after the botulinum toxin therapy to evaluate the efficacy and safety. And then I review the chart and where I injected how much dose was injected, and then plan the second dose or third dose treatment plan. So that's the practical way of the selecting muscles in cervical dystonia.
Here's another question. Do you use other types of botulinum toxin, like toxin B, for example, when type A fails?
Actually, I used the toxin B several years ago, but over the last 10 years, I just used the toxin A because I don't have enough reason to use the toxin B, because almost all patients with satisfied with the toxin A, but sometimes some patients show the unsatisfying therapeutic effect of botulinum toxin A. Then I think may I use toxin B, but there's a practical issue of the use of toxin B in Korea, because in Korea we all applied by the Korean national insurance system. They do not provide the toxin B, so there's no chance to use the toxin B over the last 10 years. So my experience is most experience was toxin A rather than toxin B.
And your timing is perfect, Dr. Chung. We're coming up on the end of 10 minutes of the question and answer. So, and there doesn't seem to be any more questions. So thank you again for your time and a wonderful presentation. And as with other previous webinars, this presentation will be recorded and available on demand for 1 year at our website, www.iaprd.org. And with that, I'd like to thank you, Dr. Chung, again, and have a good day.
Thank you so
Bye-bye.
much.